Hey guys, today I'm going to be just going over antipsychotics. So this is basically going to be just talking about the side effects, which include from the first generation to the second generation. So what are they used for? They're basically used for like schizophrenia, psychosis, bipolar disorder, but you may also see them in depression or chemical restraint, basically any form of psychosis that may be evolved. So your first generation is typically known as typical antipsychotics, and your second generations are typically known as atypical antipsychotics. And then choosing which one will often revolve around the side effects that may be beneficial. So for example, olanzapine is more likely to cause weight gain compared to most other antipsychotics. So you may want to avoid this in somebody who is obese. But if a patient is anorexic and very skinny, it may be beneficial to use that one compared to other antipsychotics. So let me just... This one would keep giving me problems. Okay, there we go. So primarily, these ones primarily block the D2 receptors. So if you block the D2 receptors, this is likely to cause extrapyramidal side effects and tardive dyskinesia, which is that oral facial movements and lip smacking and tongue rolling. So if a patient presents to the pharmacy with like that lip smacking and tongue rolling, I don't know how to describe it. Like maybe if you've seen like the Johnny Depp and Amber Heard trial, there was that one weird guy who was doing that weird tongue rolling thing. That would probably be the best way to describe what it kind of looks like. But that can indicate like an overdose of the medication. So you might want to stop the medication and inform the doctor if you ever see a patient like that. Just to note that the first generation antihistamines are less likely to cause the metabolic abnormalities that you may see in second generation antihistamines. I mean antipsychotics, second generation antipsychotics. Sorry guys. So you got your low potencies, and I think the only one you need to worry about is chlorpromazine. That was the one you'll probably see more likely. And with the low potency ones, you're more likely to cause the CV effects, sedation, and QT prolongation, as well as the anticholinergic effects, weight gain, and photosensitivity. So they're basically like the closest to the second generation antipsychotics. So that's how you can kind of think of that has like a little bit of the metabolic abnormalities, but not as potent as the ones in the second generation. And the high potency is haloperidol, and you can kind of remember that with they both H, so H for high potency. And they're more likely to cause like the tardive dyskinesia, EPS, and then hyperprolactinemia is another one that kind of you'll usually see with the D2 receptors. So fun fact, like something like domperidone, which blocks D2 receptors, also causes hyperprolactinemia. And you also have to watch out for the neuroleptic malignant syndrome as well, which is it's a rare side effect, but it can be life-threatening. And then pretty much all your antipsychotics are going to be substrates. This also includes your second generation as well. First generation antipsychotics you'll rarely see in use, but they're more commonly seen as chemical restraint, and that's usually the haloperidol. So if you ever watch like an episode of House, you'll always see them kind of say like, get me one administer Haldol right away, and that's usually because they're trying to do a chemical restraint. Second generations, they block the D2 receptors and your 5-HT2 receptors, and as a result, this is more likely to cause metabolic abnormalities, elevated glucose, lipids, weight gain than your first generations, but this is less likely to have that EPS side effects, so the extrapyramidal side effects. So before I get into the actual side effects, I thought maybe I'll drop some facts that'll make it easier to understand. So olanzapine is structurally similar to clozapine. So in terms of side effects, you'll kind of see similar side effects between these two, except the agranulocytosis. And the seizure risk, I think, is also another one that you won't really see. But usually, for a majority of side effects, if olanzapine is high risk, usually you'll see clozapine as a high risk as well, and usually vice versa. This is not always the case, but in majority of them, you'll usually see the two in hand. So just to go more in depth with clozapine, it's basically like your nuclear option. And the reason I say that is because it should be reserved if either 2 antipsychotics fail or the patient is suicidal. And the reason for this is because it causes neutropenia, and patients must have a white blood cell count of at least greater than 2 times 10 to the 9. And you're going to test this at 2-week intervals for the first 26 weeks. But I usually remember that with half a year because there's a 2 in it. So 2-week intervals for half a year. And then you're going to do 4 weeks after. And that neutropenia can lead to agranulocytosis, which is basically the destruction of your white blood cells. And in addition to the white blood cells, it can also cause fatal myocardosis and cardiomyopathy. So it is extremely cardiotoxic. And if there's high fever, greater than 38 degrees Celsius, you need to consider neuroleptic malignant syndrome. So that's why I kind of see this drug as more like the nuclear option. So you won't really see it unless pretty much most of your treatments fail or the patient's suicidal. And then aripiprazole, this is kind of like the opposite, I guess you could say it is, because it's the partial agonist of both receptors, and it's thought to have reduced extrapyramidal side effects as a result. But in general, you won't even see this as like a high risk in most of the adverse drug reactions. It's actually pretty much little to none. So it's pretty much a great alternative for most patients if they're experiencing those side effects. All right, let's start off with the anticholinergic side effects. So I just want to note before I get into it that all these drugs do have potential to cause these ADRs, but I'm just listing the ones that are more likely to cause. So anticholinergic, so that's going to be your clozapine, olanzapine, and quetiapine. I just realized this spells out COP. So you can see that these three are pretty much going to be the highest for other ones that are kind of related to the anticholinergic side effects, like sedation, for example. So that's also going to be clozapine, olanzapine, and quetiapine. And another thing I want to add is quetiapine quiets the mind. So you can kind of relate that to the anticholinergic side effects and the sedation as well. And then weight gain, increased BGLs, dyslipidemia. Again, it's your COP again, so it's going to be clozapine, olanzapine, and quetiapine that will cause that weight gain, increased dyslipidemia. But probably the biggest one that we will associate with it is olanzapine. And you can kind of remember that it has that O, like at the beginning. So olanzapine starts with O, and it kind of looks like a giant mouth that eats everything. So you can kind of associate that with the weight gain. Pretty much all the antipsychotics, if you're going to associate one of them with weight gain, it's always going to be olanzapine. So orthostatic hypotension, that's going to just pretty much be your clozapine and olanzapine. And remember, clozapine is very cardiotoxic, so that's why you can kind of associate the cardiotoxicity with hypotension, because heart, hypotension, they kind of go hand in hand. And then your seizure risk is pretty much only going to be your clozapine. But just to note, the other antipsychotics can still cause these side effects, but most of the exam questions that you'll get will be like which one has the highest risk of causing it, and these ones are the ones that will cause the highest risk. And then next one is sexual dysfunction. So high risk for this one, it's a little bit of a change. So it's olanzapine, quetiapine, and risperidone. Clozapine, interestingly enough, doesn't have as much as a high risk of sexual dysfunction. And then you also got hyperprolactinemia. So this will be your risperidone and paliperidone. And I think risperidone and paliperidone are somewhat similar, but you can kind of remember it with the aridone or the peridone, I guess. Peridone. So they're kind of similar in that regard. But another way to kind of remember it is people often whisper, like whispering, about the embarrassing side effects of risperidone. And so that's how I kind of remember the sexual dysfunction and hyperprolactinemia. And then EPS and EPS side effects. So remember, SGAs are not as likely to cause them as much as FGAs, but they're still present in causing them. And you'll probably see that more with the risperidone and paliperidone again. And then I guess this one would just be like your odd ones. So actually, no, this will be the last one actually. So this one would be QT prolongation. So that's going to be ziprasidone and acenapine. And the way I remember that is the only two antipsychotics that cause QT from A to Z. And that would be acenapine and ziprasidone. And then I just wanted to include this one in here because I didn't know where else to put it in the slides. But lorazepam, not really high risk in a lot of places. Actually, it's not likely to cause QT prolongation. But the interesting fact about it is you need to consume at least 350 calories of food when taking that medication. Okay, and that pretty much covers the antipsychotics for that one. I might do another lecture that just kind of goes over the maybe schizophrenia or something, if that's something that you guys might be interested in. But I thought I'd just include the overview because um, the confusing thing with antipsychotics is just the side effects. But if you can understand the side effects or know which ones cause which side effects, then you're pretty much golden with the use of antipsychotics as well. All right, thanks guys.